Hello, everyone. We're going to start this semester with abnormal uterine bleeding. Sorry, the course number is on this particular slide incorrectly, and this lecture is courtesy of Dr. Wu. So, these are the objectives for your lecture. Basically, we're going to talk about all types of abnormal uterine bleeding, anything from no bleeding to abnormal or excessive bleeding. It's very, very common that you will see, a common reason that you will see women in the office, other than pregnancy, probably the most common. So, abnormal or heavier frequent menstrual bleeding has a tremendous healthcare cost. The latest statistic here is about 80% of bleeding, and they have a higher cost of healthcare. So you also want to take that out into personal costs. So women who are unable or have difficulty paying for sanitary or menstrual products, and we all know those items are quite expensive. So here are some classifications and terminology for abnormal bleeding. Again, there's the definition of there, right there on the side. So it may or may not be related to the menstrual cycle, and that's something that you really want to keep in mind. If you remember back to, never mind, we haven't talked about that yet. So we can have just physiologic issues of something that's going on, but typically there's some sort of pathology behind abnormal uterine bleeding, and it's our job to figure that out. She mentions here the new nomenclature. I just want to mention that because you may still have preceptors who are using old terminology. So if you run into anything that's really not the wording or the ICD-10 that they're using doesn't exactly fit, that's okay. I will let you know what should really be used. But so when you see old terminology, I want you to, we'll kind of go over what those things were called. On the right is something that you need to add to your WHMP Bible. The palm coin, or coin, however you want to say it, is a system of, it's kind of an algorithm for figuring out what is happening behind abnormal uterine bleeding. So the palm relates to structural abnormalities. So if you'll think of the palm as a structure of your body, that may help you remember that. So polyps, which are benign, typically growths inside the endometrial lining, that is your P. Adenomyosis, which is an A, basically that's a thickening of the wall, so the uterine muscle itself, and we'll discuss that further. But it's basically a very firm tissue that grows. It's normal tissue, but it grows. The endometrial lining grows into the muscle of the uterus. The leiomyoma, which are, of course, are fibroids. So particularly the ones that are submucosal or in the muscular wall. And then the M is malignancy and a hyperplasia. And those are typically endometrial. Hyperplasia is what happens before a malignancy. So you can think of that word related to dysplasia, which is an abnormality of the cervix, right, that can become cancerous. And then the coin or coin side of that is a non-structural abnormality. So if you think of a coin as not being a structure of the body, that may help you remember that. So these are all other disorders that are not related to anatomy. So coagulopathy is the C, right? So we can have abnormalities of blood clotting disorders that can cause heavy menstrual bleeding. Ovulatory dysfunction. So even though the ovary is a structure, we're talking about the dysfunction of the ovary. So that's typically related to hormones, and that's the O. Endometrial, that can either be related to a hormonal dysfunction or like postmenopausal, those types of things. Iatrogenic means that's typically something that we have caused. And N is not classified. So anything that doesn't fit into all of that system is considered not yet classified. So that also helps us narrow down the causes of abnormal bleeding. So physiologic, pathologic, and pharmacologic. And the disruption of the endocrine function that can change the menstrual cycle. So, we've learned all about all of the endocrine glands, the hormones that relate to menstruation. So, hopefully, now you start to understand why that is so important to understand. Because if you know normal, then you can start to determine abnormal. The very, very, very first thing you do is if a patient comes in with abnormal bleeding, no matter what, if she has an IUD, she has her tubes tied, you must do a pregnancy test. So again, this is going a little more review into the palm coing system. Okay, so polyps. You could have a cervical polyp, which we have discussed. Cervical polyps are you tend to see those mostly when in women who have postcoital bleeding. That bleeding can be anything from bright red, super scary, to spotting with or after intercourse. Those are just typically benign. We can remove them in the office, as we talked about. They can grow back. So you definitely want a woman to know that, hey, first of all, this is what this is. Do you give me permission to take it off? I always remind them this is typically absolutely benign. It's just growth of, extra growth of tissue that shouldn't really be there. It's a really good way to say it. And we always, anytime we take anything off the body or out of the body, we send it to pathology for them to look at. And remind them that whatever caused this to grow in the first place, likely the polyp will return. So if she starts to have symptoms again, you're going to have her come back. If you see it again at her next annual exam, you'll take it off again. Then you have a polyp in the endometrium. These are typically benign as well. You tend to see them in women like 40 to 50 years old. And then you commonly will see it on ultrasound. So if you are scanning someone to try to figure out why they're having abnormal bleeding, then the technician may be able to see something. And typically the report such as that will say, cannot rule out endometrial polyp or likely a polyp. They can be diagnosed on hysteroscopy or what we call the easy way to say it is a saline sonogram. And that can be done in the office depending on where you work. It's a procedure where the NP with additional training from a physician can insert a very, very small lumen catheter into the cervix and inject sterile saline. This will open up that potential space of the uterus while the sonographer scans. So this will let us see, kind of think about something floating in water. So if that polyp is a little finger-like projection and we open up the potential space of the uterus with fluid, it is much easier to see a polyp. So that's a saline hysteroscopy. So if you think of oscopy, we know that means look, and hyster means the uterus, right? So we are looking inside, really can see the uterine lining there. Those can often be removed depending on where you are. Some places still do in-office anesthesia. A lot of these just need a cervical block or a local anesthetic, but a lot of times these are done in the operating room. If it is a woman who is older and isn't planning any more pregnancies, sometimes they will remove the polyp and then do like an endometrial ablation, which is where the endometrial lining is cauterized to try to keep it from coming back. Okay, then on the right is adenomyosis. So again, that's endometrial tissue that is grown into the uterine musculature. I had it described to me by a physician as gristle, that really tough piece in a steak that you almost can't chew. So it's normal tissue. It's just where it's not supposed to be. And it gets really, really hard. And if you think about what the uterus is doing to, expel menstrual blood and to keep stop from active bleeding, that's a really firm piece of muscle that the uterus can't contract. So it's contracting around that, but that area, that tissue is so firm that it cannot squeeze down. So you can have extra bleeding from that tissue there. So the L is on the right. So again, these are fibroids. You can see from that image the different types of fibroid. You have the subserosal, so that is inside the serous layer of the uterus, so that's that external wall. You can have the submucosal, which is between the uterine lining and the mucosal tissue, which is that interior lining of the uterus. You can have a pedunculated, which you can see there. There's one that's inside the uterus and there's one outside the uterus. Typically the ones outside, unless they are big and causing pain, since they are not affecting the submucosal or the intramural tissue, a lot of women don't have fibroid or issues with those types of fibroids, again, unless they're large. The top there is the intramural, that is in the muscle layer. So those are the three types. The M is on the left, which is malignancy and hyperplasia. You're typically going to see this over 35. And if we think back to what we learned about obesity and chronic anovulation, which we'll talk about soon, when a woman is exposed to quite a bit of estrogen over her lifetime, which means that she either is not ovulating regularly and shedding the uterine lining, and it tends to happen again age over 35. So in endometrial cancer, where there are cellular changes in that lining of the uterus, or an actual endometrial cancer where that hyperplasia has started to change into malignant tissue. The Cohen, those are the non-structural abnormalities. So we talked about C clotting disorders. O is ovulatory dysfunction, which we'll spend a lot of time talking about. So anovulatory bleeding, amenorrhea, ovulatory abnormal bleeding. And then you've got the E, the I, and the N, which we've already talked about. So some special considerations, any trauma to the genital tract. I've seen women who've had quote unquote rough intercourse and have had some trauma to the genital tract. That obviously takes some additional questioning to make sure that everything was consensual with the act. Some women can have tearing or kind of some sloughing of tissue from tampon use, particularly. Removing that tampon when it is still dry we all know can be very uncomfortable. That can actually tear that very fragile vaginal tissue. Um, by menstruation, most young women do not have an intact hymen, but they may still have that hymenal ring there in the posterior fourchette. So you may see that is an area that will have bleeding. Since that's intact tissue, that typically will be bright red. And then similar to the first issue, sexual assault. Okay, so first we're going to talk about the outflow tract causes of abnormal bleeding. So obviously the outflow tracts are the uterus, the cervix, and the vagina. Any of those abnormalities are obviously going to interfere with flow coming out. One of those are the Mullerian abnormalities. And here are a list of those things. If you find any of those, they're just going to be referred to a physician for management of that. And those are congenital. Again, if you back to the hymen, if a young woman does have an intact hymen and she has started to menstruate, obviously that menstruation, the menstrual blood cannot leave the vagina. That is quite painful. And because that blood is building up in the uterus, the vagina, and putting a lot of pressure on that very thin tissue there. So that's typically pretty uncomfortable. So using your interviewing questions, so your HPI and your old carts and your review of systems should be guided by that Palm-Cohen question, the classification system. So obviously medical history, family history, menstruation and contraceptive history, medication issue is a big one. Your physical exam, you're going to do an overall physical assessment, a pelvic and a speculum exam, and then a bimanual exam. So a pelvic exam is assessing externally. So you're looking at the vulva, and the vaginal opening. This would be a way that you could see that intact hymen or hymenal ring that's still there. Speculum exam is going to allow you to look at the vagina, the vaginal tissue, and then, of course, the portion of the cervix that you could see. So this is where you would see any tissue damage, any scarring, any tearing of the vaginal tissue. The cervix, cervix can also bleed when it is infected or very friable. You're going to have also some bleeding with that cervical ectropion, where we learned about the cervical development last semester, the semester before that. And then the bimanual exam is going to help you assess the size and the contour of the uterus. So you're also looking for tenderness, the position of the uterus, its size, is it tender on exam? Some diagnostic testing is going to be guided by your old carts and your review systems, as always. And then again, in your exam, there's a guide for laboratory testing in your gynecology book, and I will have that listed in your readings. Kind of a general list of things that you're going to test for are here. As I said, pregnancy test is always, always at the top of your list, unless they don't have a uterus. So someone can still have abnormal uterine bleed or abnormal bleeding. And even though we call it abnormal uterine bleeding, we're going to call it something else. But she can still have abnormal bleeding, but not have a uterus, right? Because we know some women who have a uterus some women who don't have a uterus still have a cervix. So you got to go in and see if that's an issue. And then you can have vaginal tearing. You can have vaginal atrophy that's causing tearing, or trauma to the vagina or the vulva. So these are some general tests that you're going to choose to do guided on what you already know. Again, then this will all be in Canvas and in your reading, but that's going to help you come up with, before you start testing things, you're going to come up with that differential diagnosis list and then decide what you're going to do for laboratory assessments. Some of those are going to lead to endometrial biopsy, some to sonography, some to that hysteroscopy that we talked about, rarely an MRI or a CT scan. A pelvic ultrasound, particularly a transvaginal ultrasound, is the very best picture of the uterus and ovaries. But sometimes you may need additional testing. So let's say a woman has an IUD and you don't see the strings, and the sonographer doesn't see it either. So this person is going to need an abdominal x-ray to see if we can visualize her IUD that could potentially be outside the uterus. Your goals for treating abnormal bleeding, obviously you want to normalize it or correct that. It takes quite a bit of menstrual blood or even long-term menstrual blood loss to cause anemia. But based on your assessment of how much, how long, any symptoms that she's having, checking a CBC there's nothing wrong with that. I personally don't always do it unless I'm concerned. But if that is something that is done in your office routinely, or if you just have any inkling that she may be anemic, then definitely go ahead and start that. Obviously, a treatment is you want to prevent cancer. So like we talked about that hyperplasia. And then last but certainly not least, we want to restore that quality of life. So no one wants to be bleeding more days of the month than they're not. No one wants to have, let me back up. Abnormal uterine bleeding is not always associated with dysmenorrhea or pelvic pain with menstruation. Often it is, but it is not always. So as we get into our history collection and review of systems, that is something you want to assess for because it will help you guide. For example, a cervical polyp does not cause pain. Fibroids may cause pain, not always. So that is going to be part of your assessment. But yes, if they're having pain, that's obviously something we're going to make better too. Treatment basically falls in between acute and chronic. We're going to start with acute but non-life threatening. So again, this is that table that will be in your GYN textbook, and I will probably have this in your module as well. Usually, this would be managed by one of the four methods on the right there. This is kind of listed in order of what you're going to do. I don't necessarily agree that. I think that NSAIDs can actually decrease menstrual bleeding, but this is heavy and acute. So unless she's having pain, we're going to start with hormone therapy. Now, when you get into an issue where you have someone who cannot use any type of hormone, then we'll talk about other options, and that's most likely something that you're going to have to refer. And then obviously we still need to know why this is happening. So you have an option of estrogen therapy, and that's listed there on the right. The thought behind that is to stabilize that lining, right? So think about estrogen in a birth control pill, which we've talked about at length. The estrogen maintains or stabilizes the lining. I know that sounds backwards because we actually don't want to give her extra estrogen if that is your thought process about that she has an estrogen excess and that's why she's bleeding. But the goal is to replenish that estrogen so that it stabilizes the lining. Um, that is a dose that you give and then you taper off to see what happens. Now, someone can have bleeding from not enough estrogen. So, obviously, that's something that you're still going to have to determine the etiology behind that or the pathology behind that. But that is one of your options. High dose estrogen therapy. So, if you see right there, if you can see the dosing there, that is conjugated estradiol, and that's 25 milligrams IV as needed. So that's not what we're doing in the office. So then your other option is conjugated estrogen, 2.5 milligrams for 4 times a day for 2 to 3 days. So, and then you can add like Depo-Provera, something like that. Or just progesterone for 10 days. And then, like I said, you're going to taper those off. If you think about how much hormone you are giving that woman, likely that's going to cause a lot of nausea. So often if you are prescribing a dose like this, you do want to give her either some sort of antiemetic. Most commonly I give Zofran since it is generic and you can get it pretty inexpensively now. So that's typically what I give because it doesn't make women sleepy, or at least as sleepy. You can give them an oral contraceptive 2 to 3 times a day. And there is a taper dose SIG for that I will provide for you in the module. Then you have progestin therapy. That's only if the endometrial lining is normal or increased. So even though we make her stop bleeding with one of the things we're going to continue to do, you want to continue that for at least 3 weeks. And then you're going to, so you're going to start it for 7 to 10 days and then decrease it to once a day for about a week or 10 days. So medroxyprogesterone acetate, MPA, 10 to 20 twice a day, or norethindrone. Progesterone is an option. It's typically not your go-to drug unless that's just on formulary at your facility. So the norethindrone is the same that's in a progestin only, or most of the progestin only birth control pills. And then for acute, but also prolonged. So someone who has, it is acute bleeding, but the heavy bleeding has been going on for a while. If you will give them a monophasic birth control pill, so that's that same dose every day, and then they're going to do that regimen there. For a long-term or chronic management, let's say you work this woman up and nothing really seems abnormal. And you may see this with younger women whom the HPO axis hasn't quite matured, and we need to manage everything until that maturity occurs. So you can give them cyclic progesterone, which you give them that for 10 to 14 days, and they have that withdrawal bleed. So just like with a combined birth control pill, they will have that withdrawal from progesterone and bleed. And you do that every 30 to 40 days to keep that menstrual lining stabilized and then expelled. Any form of combined oral contraceptive, if she's a candidate for that. Oral micronized progesterone, that's the option there. That micronized progesterone or prometrium is really considered the safest form of progesterone, but really that matters if you're giving it long term. So like if you're giving it in a postmenopausal woman who's on estrogen, we're more concerned about that long-term dosing. But typically with someone like this, you shouldn't be needing to give something long term. Depo-Provera is a beautiful management in someone who does not plan for pregnancy anytime soon. Since that's progesterone, we can give it at any age. And for anyone who can't have estrogen, but progesterone is okay. The most beautiful option is your Mirena or any form of LNG IUD. So that's non-systemic, works locally, thinning out the lining of the uterus. So if you're someone with long-term menstrual bleeding that's abnormal, sometimes you will actually make them have a withdrawal bleed or a menses. To kind of, the way I describe it to a patient is to get everything that's out. That's everything that's in. Let's let it out. And then we're going to put this IUD in the uterus and tell it we don't want that anymore. But for those patients, it may take a little bit longer to get that bleeding under control. So they definitely should know, if irregular menses is their issue, our goal is to help that disappear. So they may still continue to have irregular menses, but again, it should be lighter, more spotty, over time. Even though, like I said earlier, if they're not having pain, NSAIDs, so ibuprofen 800 every 8 hours, starting either before they know they're going to bleed or immediately when they start having bleeding. The way that breaks, it adjusts how the prostaglandins break down in the endometrial lining. That can help decrease the amount of uterine bleeding or endometrial bleeding. Tranexamic acid, also known as Lysteta, is a distant cousin of ibuprofen and other NSAIDs, but it is a beautiful thing for heavy menstrual bleeding as well. We'll go over that medications a little bit later. So these are some particular drug names that kind of we already talked about there. This is the dosing for your NSAID therapy. I said 800 3 times a day, which is a prescription dose. But if you think of ibuprofen, 400 every 4, 600 every 6, 800 every 8, that's a really good way to remember it. But obviously, if you have a very thin patient or someone who is not going to eat with their medication, you may want to consider, 600 every 3 to 4 hours, something like that. Or someone who says, oh yeah, I don't have any problem with that, I take that all the time, then that's an option. Naproxen is also a good option for any of those. Lysteta is the best, and it does come in that generic now. These are some surgical management options for heavy menstrual bleeding. So, you're going to try to determine your diagnosis. If your diagnosis is something that needs to go to the physician or the surgeon, you just do that right away. If you cannot figure out, you've gone through your PalmCoin list and there's either nothing definitive or there's something that you don't know how to manage, that goes to your physician or your surgeon. If you know what is going on and it is in your ability to try to correct, then you do that. If you try a first line and maybe even adjust it a bit, and let's say you try a first line, it gets a little bit better, you can try a second line there. You can change her birth control pill, give her a different NSAID. But if your first line therapy doesn't do anything, I might just do what I call a curbside consult. Just stop and say, hey, this is what's going on with my patient. This is what I've tried. What would you recommend that I try next? Or would you like to see her? So again, that's going to depend on your agreement with your supervising physician or the guidelines of your facility. So again, this is telling you a little bit about why we do that exam. For ovarian function, you're looking at, estrogen, progesterone, FSH, all of the parts of the anterior pituitary, and what the what the ovaries are producing in response to that. The thyroid and hyperprolactinemia are causes of heavy menstrual bleeding. So, with the hyperprolactinemia, you're typically going to have that galactorrhea, and you're going to see that elevated prolactin. Here's a list of differential diagnoses associated with amenorrhea. Okay, so now we're going to go back to, sorry, if I didn't say that specifically, this is a diagnosis and management of amenorrhea. Amenorrhea means no menses. That can be for a month. Let's say she skipped a menstrual period and she's here to see you because she hasn't started her second one, or she just missed one. Maybe she's never had one. Maybe she hasn't had one for months and months. So you're going to see that presentation for all sorts of different reasons. But here on the left are the reasons, the most common reasons you're going to see amenorrhea. The number one cause of amenorrhea is pregnancy. Pregnancy. In someone with lactation, they may or may not have menses. A lot of women do not. Hormone contraceptive use, obviously that can, depending on how we're doing that, can make them stop having menses. So that goes back to your patient education when you start them on any medication or device. And then menopause. So the definition of menopause means there has been no menstrual bleeding for 12 consecutive months. We will talk more about peri and menopause when we get to that module. But if someone has bleeding after that 12 months, then we have an issue. Obviously, we don't expect a calendar year 12 consecutive months without menstruation in someone who's 35 or 40. That could be premature ovarian malfunction. So hopefully that, or failure, that's someone that's probably not going to wait 12 consecutive months to come in and see you. The outflow tracts, we talked about that. We'll talk about those diagnoses more in detail. Those congenital anomalies, acquired. We talked about the hypothalamus. So remember, the hypothalamus is that one level up from the pituitary gland. So you don't ever want to forget going up that high in the chain or the sequence of events. This is a list of amenorrhea. So primary amenorrhea. Primary amenorrhea basically means they've never had a period. And I will give that definition to you broken down by age. And then for secondary amenorrhea, again, that same list is there, but you can see pregnancy is always at the top of both of those lists. In ovulation, that is what we talked about, where endometrial cancer can occur. If you don't ovulate, you don't menstruate. If you don't menstruate, you don't ovulate. So that cycle left untreated can cause many, many problems. So in someone who has chronic anovulation, and we'll talk about the reasons that happens, that is always something that we need to fix. Again, ovarian failure. So that can be you have a low estrogen level when you check blood work, and you have a high FSH. So if you think about the FSH and the estradiol like you would your thyroid. So your TSH is telling the thyroid to produce thyroid hormone. And when it is high, that means the thyroid is not responding. When it is low, it tells you that the thyroid is over responding. Same thing for any stimulating hormone, but for us, we're looking at FSH. So if the FSH is high, that means that the ovaries are not responding typically. So we've got hypogonadism or hyperprolactinemia, which we talked about. And then you can have functional amenorrhea. So there's something going on with the patient that is maybe kind of exogenous would be a good way that I would say it. So she's underweight, she's overexercised, she's stressed. One of the things that you always want to think of in an underweight patient presenting to you is that, do we have an eating disorder going on here? Over exercise. So if you think of when someone has, so if they exercise so heavily that they have basically zero body fat, and you can think about this like long distance runners who have that very thin body, or gymnasts who have that highly muscular body. Because of that low level of fat on the body, you can have a very low estrogen level. Estrogen is always related to fat tissue, or just being so stressed out that they can skip a period or not have a couple in a row. This is a very nice algorithm for the assessment of amenorrhea. I may have this particular book. If I don't, I will put the algorithm from 5-Minute Clinical Consult into your module. If you print out slides, then you'll get this here. So you're going to rule out pregnancy, menopause, and you're going to go down this track here. Now, obviously, this isn't telling you a management plan, but it is helping you reach your diagnosis. For special considerations, in adolescents and young women, we are trying to think of menstruation or the menstrual cycle as a vital sign. So, our menstrual regularity, flow, length do tell us a sign of overall health. So that is where that really detailed medical history comes in. If you do have a young woman in the room and her mother or parent, guardian insists on staying, sometimes you're not going to get the most accurate history depending on the dynamic between those people. Some moms will take over and tell you what her assessment is of the menstrual cycle. So if that's happening, sometimes you're going to have to do a little kind redirecting, maybe ask the mom to wait. And I say mother, but any parent or guardian is what I'm saying. They are more likely to step outside of the room if you explain to them why you're doing that. So, we tend to get better information when it's just your daughter, your sister-in-law, whoever is there with her. And it's really my goal to develop a relationship with her so that she's comfortable coming back to see me over and over again. Most parents, guardians are happy to do that because they do want you to have a relationship with them. When they are not okay to leave, I get a little more interested in that. But that's a whole other talk. So for these young women, medical therapy and nutrition counseling. So some young women are going to be overweight, and that's why they're having menstrual difficulties. Some are going to be underweight, and that's why they're having menstrual difficulties as far as nutrition goes. Talking to a young woman about weight, whether that's under or over, is a very sensitive topic. As you know, we are all grown women, and we don't typically want to talk about our weight. So if we think about what all is going on in young women in adolescence, in their, Erickson's developmental model, they are trying to figure out who they are. So a sense of self, fitting in with friends, pulling away from their family, and trying to fit into friend groups. They're also very, since women or girls develop earlier than boys or young men, they do receive a lot, tend to receive more attention for their bodies than their brains are capable of understanding. So now, if we're going to add on a weight issue to all of that that's already there, that is a very, very tricky counseling session. Now, most women know that they are overweight and they are very self conscious about it. Unfortunately, some young women are kind of really given a hard time by their parents, especially if their parents are thin. So you really want to approach it as nutrition and healthfulness and how it will hopefully help correct their menstrual bleeding instead of that, this is your BMI, this is what I need you to do. It needs to be a very thoughtful conversation. Women with disabilities. So you that can be very challenging, right? And you're also going to have caregivers of women with disabilities. So kind of depending on that spectrum of what is going on with this particular patient. So having that direct communication directly with the patient is very important. And you can use your therapeutic communication to assess exactly what you need. Um, Let me see what's on the other side. So it may mention it later, but I'm going to throw this in after disabilities. Um, Women who are either um, transitioning from male to female or female to male, they're going to have different menstrual needs or requests. So I have taken care of several patients who are transitioning from female to male. And, obviously, menstruation is not something that a male gendered person would do. So we have figured out ways to stop menstruation. An IUD is typically the best option for those women those trans men, because I'm not giving them any systemic hormone, which they may be at the point in their transition that they are on testosterone. So we don't necessarily want to give them an additional one. But I typically go based on what the physician or the NP that is managing that transition, what they recommend. So around perimenopause, which can start anytime in the 40s, so that basically peri means the years leading up to menopause. A lot of women will have heavier bleeding. Maybe, the periods can start to get the menstrual cycle, the menses starts to become more irregular. So you'll have someone get really excited because they've missed 3 periods in a row and they're 48 and then they come back. So that abnormal or irregular bleeding is something that you definitely want to start to talk to your patients about, around 40-ish. Menopause is also coincides with what the familial history is. So, a lot of women do something similar to what older sisters or their mother or their, aunts have done. So when you are, that those are good questions to ask when you are assessing for this, or if a woman is asking you just, when am I going to go through menopause? That's a really good way to look at it. So again, education, regular exercise can help manage menstrual regularity and the amount of bleeding. You may want to they want to modify their diet, and just to make it as nutritious as possible. If their bleeding is high or is heavy, then I would include extra iron. Food sources are best, especially in someone this is functional bleeding. Food sources are best, and calcium food sources are best. But in that perimenopausal period is when you want to really start to educate about calcium and vitamin D intake. If they smoke or vaping is smoking, they need to stop that for many reasons. Cigarette smoking, tobacco smoking can cause heavier menstrual bleeding. It can also lead to bone loss, and that's, we really need to start to think about and educate about that. For older women, endometrial cancer, the risk does increase with age for all of those reasons. So either a woman has been exposed to extra estrogen over a lifetime, and by extra, I mean from the body. So she's either not been ovulating or was on a significant amount of fertility estrogen medications, those kinds of things. And again, I will have that box listed, that table listed in your Canvas course. Regular menstruation is very important to many women. That's typically a cultural definition. So I believe I've said before that a lot of women they don't want an IUD, they don't want a hormonal IUD or Depo-Provera, or even a oral contraceptive combined, to either, a continuous dosing or even a quarterly dosing pill that would make them either stop or have more irregular light menstrual bleedings, because they think that's how they know they're normal, is that they see blood, and that bleeding will clean out the uterus. So that is something that you need to assess culturally. Okay, we're going to take a pause right here.